Good morning. I'm Fauzi Maluf Filho, Associate Editor for Gastrointestinal Endoscopy, and today I have the great pleasure to interview Dr. Yi Qin from the Division of Gastroenterology and Hepatology, Mayo Clinic, Rochester, who has recently published his research entitled Screening for Esophageal Squamous Cell Carcinoma, Recent Advances. Yi, thank you for coming.
Thank you, Dr. Maluf Filho.
Thank you.
It's a privilege.
Thank you. Your research is a review of the rationale for the screening of esophageal squamous cell carcinoma, the new tools and the results of the screening program for this cancer. Could you comment on the global situation of esophageal squamous cell carcinoma, the groups who are at risk for this neoplasia, and the rationale for screening?
That's an excellent question. Thank you. So esophageal squamous cell carcinoma is the most common type of esophageal cancer, which currently ranks as the 6th most common cancer killer worldwide. And compared to other cancers, it's actually increased in incidence by 8-fold since 1975. And the global incidence of esophageal squamous cell cancer in the developing world is still increasing. Now, when talking about risk factors for esophageal squamous cell carcinoma, that depends on a few factors: patient-related factors and environmental factors. And when talking about environmental risk factors, that can be further subdivided into 2 groups: endemic areas and non-endemic areas. For instance, endemic areas include areas in China, this esophageal cancer belt in Asia that spans from China to Iran, as well as areas in Africa. Now, non-endemic areas are areas with lower incidence, such as the US. Some risk factors that are more unique to non-endemic areas are smoking and alcohol use, which may be less of a risk factor to patients in endemic areas, such as Iran, when patients don't drink at all. So the risk factors depend on where the patient is from. For non-endemic areas, one of the risk factors we talked about is smoking and alcohol. Some other risk factors include prior radiation exposure, and so lower socioeconomic status has also been associated. For endemic areas, some of the risk factors include polyhydrocarbons in the diet, mate tea drinking.
Mate tea drink, yes, correct.
Yep. Nutritional deficiencies in selenium, and things that are not more common to the developed world, but more common in the developing world. But in general, that's the whirlwind on environmental risk factors. Patient-related risk factors include a few genetic causes, such as Plummer-Vinson syndrome, Fanconi's anemia, and tylosis, which is a hyperkeratosis syndrome of the palmar and plantar surfaces. Yes. The penetrance of esophageal cancer is as high as 90% in those patients. And of course, prior radiation exposure for patients who have had history of head and neck cancers. So.
Thank you. And which are the available screening endoscopic methods for esophageal squamous cell cancer? The endoscopic screening methods.
So we've been in a technological boom in the last few years. Traditionally, the screening tool, the standard screening tool for esophageal squamous cell carcinoma is white light endoscopy plus Lugol's. That gets you to a very high sensitivity of about 95%, but the specificity varies a little bit, between 30% to 90%, because unstained lesions can include dysplastic lesions as well as inflammation, such as esophagitis. So a lot of technological advances in endoscopy have come about. One of them, first of all, is narrowband imaging, which you know detects the wavelengths of hemoglobin, and the dysplastic patterns are highlighted on the image. That has the same amount of sensitivity as Lugol's, but slightly increased specificity. On top of that, there's image processing technology such as iScan and FICE And then FICE, especially in combination with transnasal endoscopy, has greatly increased the sensitivity of transnasal endoscopy for unsedated detection of esophageal cancer. So and then there is this high-resolution microendoscopy system that has become more and more portable and deliverable to remote areas. So there's been tremendous improvement in endoscopic advances for detection of esophageal squamous cell carcinoma.
Absolutely, yes, you're correct. And what about non-endoscopic screening methods?
So that's the area that we focus on a lot. So as you can imagine, for a high incidence, resource-rich area, it makes sense to screen everyone with an endoscopy. There's actually been a 10-year community follow-up study published by Dr. Wei et al. From China in an area where they randomly assigned communities to screening by one-time Lugol's endoscopy or no screening. And that has found a reduction in cancer-related mortality by 33% at the end of 10 years. Now that's a high incidence, and they've added the resource in for that community. So it makes sense to screen for those communities. But for the rest of the endemic countries that lack the infrastructure, you really need a cheaper non-endoscopic tool. So Dr. Dossey's group has actually done this very interesting studies with sponges and non-endoscopic cell collection devices. So sponges, balloons, meshes in China in the 1990s. However, it's basically a cytological test. So a patient can swallow an encapsulated sponge by gelatin that opens up when it gets into the stomach. They can swallow a deflated balloon that can inflate when it gets into the stomach, or a brush or a mesh. And when those things are pulled out of the mouth, it collects all the cells from the esophagus. So if we're only looking at the cytological elements of that test, the sensitivity is pretty low, between 20 to 40% for esophageal cancer, which was quite disappointing back in those days. So those have not been in use as screening methods yet for esophageal cancer.
Very good. And could you comment on breath tests for cancer screening? Should we train our dogs for cancer screening?
I love that question. So Dr. Sonoda's group is the one that came up with a really, really interesting and creative study published in Gut in 2011, I think. The star of that study was a black Labrador retriever, 8 years old, female. Now, that dog spent 4 years training in a cancer dog sniffing facility where she sniffed hundreds of stools and breath samples from patients with cancer and at least 500 controls. Every time she got a cancer patient correctly identified from a group of non-cancer patients, she was given a treat. Now the treat was not food, actually. I was surprised. It was play with tennis ball. So after 4 years of that training, she went on to do this study. And the study was found a very high sensitivity.
Amazing.
So they looked at breath tests and stool samples. So the black lab was able to detect colorectal cancer in that study with a sensitivity of I think 93% for breath and 97% for stools. Amazing. At a specificity of 99%. So since that study, there's been lots of advancement in technologies that are trying to simulate and replace the canine nose. One of the studies, and I think the only study that we have so far, is a study out of China on esophageal cancer. They didn't specify on if it was esophageal squamous cell carcinoma, but it was 29 patients with cancer versus 50-something healthy relatives of the patients, and they reported an AUC of about above 0.9 for that test, but there was no mention of blinding in the study, and so that should be taken with a grain of salt. So I think to answer your question of should we train our dogs, relatively speaking, the average American gastroenterologist spends 3 years in gastroenterology fellowship. This dog spent 4 years. If you're able to afford to send your dog to GI fellowship in Japan for 4 years, then you could.
That's funny.
Yes. Thank you.
And what about liquid biopsy, circulating malignant cells, blood markers? They are usually in the investigation for cancer screening, correct? Could you comment on the recent events on that area for diagnosis of esophageal squamous cell cancer?
Great, thank you. So that's our niche and our lab. So liquid biopsies and tumor markers, I believe, and essentially universal cancer screening, I believe will be the future of medicine, and the advances that's come about for those have been pretty rapid, and that field is rapidly growing. There's been good research on a lot of biomarkers for esophageal squamous cell carcinoma, in addition to just esophageal cancer in general. So things like microRNAs, autoantibodies, and methylated DNA markers, which is our specialty. So methylated DNA markers basically is a covalent addition of a methyl group to a cytosine in DNA without changing the underlying genetic code. Promoters, CpG islands, can become hyper or hypomethylated, leading to silencing of tumor suppressor genes or activation of oncogenes. And these signatures are present early in the disease. So the hypothesis is that we can use these markers to detect cancer, especially esophageal cancer in our specialty. So what we've done is in tissue from esophageal squamous cell carcinoma patients, as well as esophageal carcinoma patients, comparing those to normal individuals, we did an in tissue-based level whole methylome discovery to discover brand new methylated DNA markers for esophageal cancer. We took those best markers and validated them on a larger independent tissue set, and the best performing ones on the validation study went on to additional validation. So what's really cool is we just did a tissue-based multinational validation study. So the markers that we discovered from a U.S. population for esophageal squamous cell cancer, we wanted to see if those would work for detection of esophageal squamous cell carcinoma worldwide. So we had samples from patients in China, we had samples from patients in Iran, and this is stuff that I'm presenting this afternoon. But in tissue, the markers that we discovered from the U.S. patients performed just as well for patients in Iran and China, with AUCs as close to 1 as possible, 0.99.
Wow.
So that's really cool. Imagine if we can combine those to an endoscopic or non-endoscopic cell collection device, such as what Dr. Ayer's working on, the sponge on a string. Also, with the markers that we discovered, we applied them to a plasma pilot. So totally non-invasive. And this work I presented yesterday. So basically, using the best markers we discovered from the tissue-based study, we tested them on plasma from 85 cases versus 98 controls, and we had an AUC of 0.93, corresponding to a sensitivity of 78% at a specificity of 91% for detection of esophageal cancer.
Oh, that's amazing. Wow.
Yeah.
And a final question, Yi. Before those extraordinary new tools prove to be efficient and become available, how should we behave in our daily practice? Push the chromendoscopy button while we are scoping the esophagus and spray some Lugo in any suspicious area?
That's a great question. I think that depends on the population that you're practicing in, Dr. Malufiola. In Brazil, where the incidence of esophageal cancer is actually fairly high, of 6 to 10 per 100,000 patients, it would make sense to try to do that. When I did an observership in China, which also has a high incidence of esophageal cancer, patients, if they had the financial means to do it, they would present themselves between ages 40 and 50 for a screening endoscopy. And MBI and Lugol's were commonly used. So regardless of the indication, if a patient is here for endoscopy, the endoscopists, and this, I mostly saw MBI back in China. I was in Beijing, so not a very resource-poor area. The endoscopist would spend at least a few minutes. They spend the most time in the esophagus, looking under NBI and magnify NBI, all the IPCL patterns, targeted biopsies of anything that looks suspicious. So I think for high incidence and resource-rich areas, NBI, Lugol's are feasible. But again, for the rest of the world, which may lack the health infrastructure, then an accessible and cost-effective tool for screening of esophageal cancer is much needed at this point.
Thank you so much, and once again, congratulations on this nice paper.
Thank you so much, Dr. Malufiolo.
Thank you.